our website, but I did get permission to share that with you and your group as
Fantastic.
a handout that people could have.
Okay. Well, I think they will enjoy having that. And I believe Lindsay just opened the front door here, so people are going to start coming in. So you're in Ohio, Shannon? Is that?
I'm in Michigan.
Oh, Michigan. Okay, that's right. So you're anti-Ohio, according to my Ohio State friends.
Yeah, it just depends on the time of year. But we actually, I think, had Ohio rooting for us when the Lions were doing pretty good. But other than that, I don't think we're friends.
Yeah, Detroit made a little run at things this year. It was kind of fun to watch.
Yeah, put a lot of pressure on the Tigers. It's like between U of M and the Lions, kind of puts the pressure on the rest of the hockey and the baseball now.
Yeah. Scott Ray, the founder for 6 Degrees, his wife is from Michigan, Detroit area, and she is fun to hang out with. I don't know, something about the people from up there. They seem to have a lot of fun. So when she's really having fun, we call her Miss Detroit. But
it's a beautiful state. We have a lot of beautiful waters, and there's in our Upper Peninsula, you'd think you're in another country when you look at the views up there. It's just gorgeous. It's a beautiful state.
I've heard that they call it the UP or the Upper Peninsula.
We call them the Upers, and they call us the trolls. If you live under the bridge, you're a troll.
Perfect. All right. Well, people are rolling in. Welcome to the May Fireside Chat for 2024. Today we will be featuring Shannon Rozell. So, Lindsay, why don't you click us forward on the intro slide, and we'll get that part done. And then, as people still are joining, we'll get to the content. So, I had the pleasure of meeting Shannon here a few months ago. Their organization works with 6 Degrees RBP plans, or an option that folks have for accessing mental health care. And so Neil Franzer on our team on operations is the one that recommended that we have Shannon as a guest. And so a lot of the guests that we've had over Firesides over the years are people that I've known in industry, and apparently I'm running out of people, but got really lucky with this introduction, and I've enjoyed the pre-calls that we've had of Shannon. And today she'll get to enlighten everybody on the programs that they run and what they've done to very successfully help some of the youth across this country. So with that, I'll turn it over to Shannon. And as always, wait, before I always forget, I do this halfway through, but you can use the chat function to make comments, but please use the Q&A function on your browser to ask questions. I'll build those into the presentation as we go through it. Try and get everybody's questions answered. I think you'll have plenty as she goes through these things, and hopefully everyone learns a little something today. So with that, Shannon, welcome to May 2024 Fireside Chat.
All right, thank you. Thanks for inviting me. I've enjoyed the prep work and the beautiful background of my fire that you gave me. So let's go ahead and go to the next slide. So I am with Newport Healthcare, and we are branded under a couple of different names across the country. We originally were Newport Academy, treating teens and young adults ages 12 to 18. We found that there was quite a demand to continue a little bit older than that. So we created Newport Institute, which caters to patients ages 18 to 35. So what we do, our mission as far as what we do with the client, is that our ideal client is one that is challenged with high acuity mood, anxiety, depression, trauma, just having that kind of a mental health challenge. So our specialty is helping this particular individual kind of break the cycle of crisis in their life. And before COVID, there was a crisis with our youth and teen and young adults. COVID exacerbated that, and the numbers, according to the CDC, continue to rise as far as the levels of anxiety and OCD disorders that are evolving as a result of COVID. So I'm going to just talk a little bit today about kind of what we're seeing, what the CDC is reporting, and then also I'm going to focus on the different levels of care available within the mental health industry. And then I'll focus also on what our levels of care at Newport, how we cater to the different levels of care, and then what qualifications a person must have in order for their insurance to pay for those different levels of care. So Newport Healthcare is the parent company, and then under that is Newport Academy and Newport Institute. We also acquired Prairie Care in Minnesota a couple years ago that added a number of locations for us, as well as another level of care, which is the highest level of care for hospitalization. And then we also have Center for Families. But today I'm going to focus mostly on Newport. So let's go ahead and go to the next slide. So within our Newport family, we have 678 residential program beds, and that's spread across 72 locations, and 24 of those locations are also outpatient sites. And we operate currently in 12 states, and we serve patients from all 50 states. So Heath and I were just talking about, where in the states where we don't have a location, do we have partners? And I want to share with you that we have about 70% of the clients that we serve actually travel to get to this level of care. This level of care is residential, so being in your zip code or your neighborhood is not relevant. It's relevant to the clinical presentation of the individual and the needs that they have in order to break kind of this crisis cycle that they are in. So this map just displays where we are currently located. So again, just serving patients from all 50 states. And then we do have partners in all states. So we have a team of clinical outreach specialists across the country, over 60 of them. And their sole purpose is to identify partners with Newport so that when, say, for example, you see that we don't have an LA location, a Louisiana location. When we have a patient from Louisiana that maybe we send them up to Minnesota, when they come home, they have to have continuing care resources for both the family and the patient. That clinical outreach specialist that covers Louisiana is going to become a part of their continuing care plan to identify a family therapist, a psychiatrist, a therapist, an individual therapist, and perhaps even a trauma therapist or whatever that client is discharged in need of, to continue to sustain that recovery that they received while they were with us, to practice the skills that they've learned for moderation of the mood and the behaviors. So that list of clinical outreach specialists is something that I can absolutely share with anybody who's interested in knowing who your person is in your area, that can connect you with whatever resources your members might be in need of, whether that's outpatient or inpatient.
How about in terms of expansion, what's that look like, next year and 10 years down the road?
Okay, so 10 years down the road, I would love to know the answer to that question. I know our CEO has a goal of like 15,000 beds across the country. But right now, in the immediate, like this year, for example, we will be expanding into a new state, Massachusetts, for us. That'll be a new state, and that'll be a 30 client teen location in the Cape. We plan to open that in about September. That's always a moving target with all the things that you have to accomplish before you open, but we hope to have 30 teen client treatment beds by September. And then we are also opening adult services, adult locations in Washington, We'll have 2 in Washington, hopefully in the very near future in Snohomish. We also have a detox center that we just opened in California. And then let's see, there was another one here, Connecticut. We also have a Connecticut location that's going to be opening, a couple locations in Connecticut. So that's the expansion by the end of this year. And then it's easier for us to expand in states where we already exist, because we've already jumped through a lot of the governmental hoops and requirements that are in that area. So when we open in a new state, it's a discovery thing. You have to discover, what levels of care are available there, how well is it supported by the insurances in that area, what is the population density in that area. And the way that we're going to determine where we're opening new locations is how much cooperation and demand we have from there. We can predict that demand by the people that are traveling to go to other states for treatment. If we open something, we recently opened several in North Carolina and Virginia, because we were getting a lot of patients traveling from North Carolina and Virginia. So there's a lot of metrics that go into that future growth. But primarily it's going to be not just demand, but also the support of the primary insurances that are held in that area, because when people are in crisis, they want to use their insurance. So, we have a lot of different partnerships with insurance, contracts with insurance providers, so that we know that we're going to be able to get their support in those states.
But you mentioned adult expansion in Washington. Now, from my understanding, that hasn't necessarily been a focus of yours, where it's been primarily adolescent care.
Right.
Is that an area of growth that's going to be taking place?
Yes, because we're seeing a growing demand, again, especially since COVID, of that young adult. So the adult services are 18 to 35. And I've watched that adult number move from 24 to 28 to 30 to 32 to 35. So that's telling that what tells me is that that's what the demand is, that we're seeing that our particular method of treatment is working well for this age demographic, because we have a very strong family component requirement in our program. And we find that when we engage that family in what's called attachment-based family therapy, we really stack the deck for success of recovery for that teen or young adult. But also we're repairing ruptures within the family, and that really helps sustain recovery for that crisis cycle to end for that family. So it wouldn't surprise me if in the future we continue to grow that number, just based on what I've seen in the last 2 years.
Interesting.
Okay, next slide. So these are just a few of the contracts that we currently have. We have our Chief Payer Relations Officer that works tirelessly at putting together contracts with different entities. And as you can see, 6 Degrees is on here in alphabetical order.
Well, wouldn't that put us at the top? The number, I mean, that's how the conferences
I thought
work
that
out.
after I was like, I think they went with the S.
Well, Anthem carries a pretty big name too. But
yeah. So these are just a few. There are several, because we operate in a lot of different states, but we also pull patients from a lot of different states. There are many names that people just wouldn't recognize, because they're like, Blue Care Network of Michigan, for example, is a division of Blue Cross. So there's a lot of, like you see, Regions is a division of Blue Cross. Blue Cross has many silos and divisions within the different states. So we participate with them in many. So for self or the partially funded corporations, that's usually that's a big one to get, because it does seem to be dominant. But then we also have some of the clearinghouses that we have set up agreements with, so that when we have some of the like the self-funded or partially funded plans, if they don't have a contract with us, then they could go through a clearinghouse. So our goal is to bring access to care to the people that are in need of it. So while we originally started out as private pay back in 2006, every corporation has to unfortunately start out as private pay in mental health. You have to kind of earn your way into treating so many patients over so many years before you can start to get these kind of contracts. So we've got some very good contracts in place and continue to work on signing additional contracts. But kind of when we look at being the focus of like TPAs and self-funded, if you're not working partially or at all with any of these types of companies, then we would look at things like a single case agreement, or just looking at what type of clearinghouse or that you work with. For example, I work with a lot of tribes. Tribes are self-funded corporations. Typically, they have their funding set up through some use TPAs, but some are self-funded. So I just look at how they pool their money for their benefit plans, and then what makes sense for us to do with them. Would we just set them up on a single case agreement, or would they prefer to set up a contract much like we might do with one of these national contracts, and then make it easier for people to get into care? Regardless of whether it's a single case agreement or a contract in place, you have the opportunity to build within that contract what the approval process is. So for example, with 6 Degrees, when we get somebody that has that on their card, there's a phone number that our admissions calls on the back and then runs that case by 6 Degrees, and they're either going to say, we're going to authorize this, or we're not going to authorize that. You will always have that the power to decline. But the fact of the matter is that we're not going to present a case to be admitted to our care if they're not meeting the criteria that is typical of what these nationals require in order for that patient to be admitted. Because oftentimes, a mother, for example, I'll use the mom because this is typical. Mom, is seeing a little bit of a different behavior in her daughter, and she feels like her daughter needs to go to residential. She's really concerned, but the daughter's never seen a therapist. There's never been any kind of like a suicide attempt or any kind of an activity or risky behavior that has happened that has triggered the need for this level of care. We're going to then, based on her location, find an outpatient referral for her that will take her insurance. So we want to make sure that people are meeting the criteria to need our level of care. You don't want to ever place them in too high of a level of care, but you also don't want to go too low. So it's really about the evaluation and the clinical presentation of the individual at the time of whatever that crisis is. Okay, so just kind of some stats here. About 98% of our clients now are insured. They're utilizing their insurance to pay for their care. Whereas, as I said, when we started, 100% of them were private pay. So we've been able to open access to care as we've grown, both our footprint as well as our contracts within the industry, so that we can open up that access to care for people. Okay, next slide. So this is the crisis. I pulled this right from the CDC website, and it's concerning that how this number continues to grow rapidly. That homicide and suicide are the second leading causes of death for this age demographic of 10 to 34. Number one is accidents, just accidental death. Number two is intentional death. And this is where we specialize. So we take a lot of our clients as step down from acute psych care, and we take a lot of our clients as step up from lower levels of care that are not breaking that cycle for the individual. So these stats are pretty high, as far as 18.8% of high school students have reported seriously considering suicide in the past year, and 8.9% have actually attempted. And, as we look at some of the horrible things that have happened in our country with like the school or church shootings, one of the first things that happens is it comes to my mind is what was going on in their house? Where were the parents? Did the parents see this coming? Was the person getting any kind of care? Were there any signs? What did they do? What did they know? So this is kind of where one of our unique factor as far as treating the family, not just the teen or the young adult, comes into play as far as showing the importance is that when there are many places that I feel inappropriately hide behind the HIPAA law. They treat your teen or your young adult and they say, well, I can't share anything with you because that would be a violation of the HIPAA law of the Privacy Act. And to some extent, that is absolutely true and valid, but to some extent, it's also, I think, it doesn't serve the family. So by making the family a part of the treatment, we do require for every patient admitted into our program that a parents, or guardian participate in what's called attachment-based family therapy. That's built into the daily rate. So when we treat one patient, we're not just treating one patient, we are treating the family. Sometimes it's one parent, sometimes it's four parents, and sometimes it's a couple siblings too. So that's just all built into that daily rate, because what we're looking for is the relationships within that family, how they're working or not working, how the parents were parented, what they might be bringing from their childhood into their parenting and into their child's rearing, what might be working or not working for them. And oftentimes what we find is that when we can refer that parent for maybe some necessary trauma treatment on an outpatient basis, or maybe some addiction treatment, that we're repairing the ruptures that are actually affecting this suicidal child, or this child that's maybe just really struggling with different types of depression, anxiety, and ideation. So we help the whole family. Okay, so next slide. So in my as I work a lot in payer relations with talking with different payers on, why they should contract with us, where we are relevant, how we are different. And I wanted to come up with this kind of a sample to share with the contractors, but I thought that it would also be relevant for this presentation. I'm going to be talking on the next slide about levels of care, but right here I'm going to talk about this particular family story, which was pretty tragic, but it's also pretty common. When we look at what is the total cost of our care plan, sometimes we have blind spots that we look so much for where can we save money that oftentimes we're stepping over dollars to save dimes. We need to get a little bit deeper on that patient-centered care and not just kind of following a matrix, but what's going on with that individual, and based on the history and what has gone on, what is the most appropriate level of care for this person at that time. And if we put them in the appropriate level of care instead of the least expensive level of care, we may actually come out, we will come out on the end paying less. Because in this example, what this father was able to share with me, this was over an 8.5 month period of time that his daughter was taken to the emergency room 5 times for attempted suicide. So she spent 7 nights in an emergency room bed. She was hospitalized all 5 times and spent a total of 37 nights in a hospital bed. So one's ER bed, one's hospital bed, they're billed differently and not at a daily per diem. So as I'm sure many of you have seen when you see the itemized billings that come. And then she was also in this period of time stepped down from hospitalization. The first hospitalization, she was stepped down to a free program that was a county-sponsored program for runaways. And the dad said that it was just, his daughter was very angry. She wasn't a runaway, but she was put in a program that was designed for runaways. And she may have even picked up a few extra new, you know, bad maladaptive coping skills while she was there. She, once released from that, had another suicide attempt, was then discharged to a partial hospitalization program, which is an outpatient program. That cycle occurred 4 times over this period of 8.5 months. So she had a total of 77 days in partial hospitalization programs. And then she spent 32 days in a residential state-sponsored program. And the father said he was frustrated because it was run by undergrads that were earning their credentials to become therapists. And there was zero communication to the parents. So they were not given any updates on how their daughter was doing, or what she was doing, or when she was going to be discharged. It was just kind of like, today's the day she's discharged, come pick her up. There was another suicide attempt. We then got her, and we had her for 10 weeks. And during that 10-week period of time, she was making progress. She was making good progress. She was very angry at her parents for all that she had been through, so she didn't want to engage in the family therapy, but they still had family therapy as far as the family therapist worked with mom and dad on kind of honing their skills for communicating with their daughter, and listening to her. And then also worked with her on how to present herself to her parents so that she could be heard and understood. So there was progress made. We were not ready to step her down yet, but the insurance contacted the father and said, basically, we're done with you. Your mental health benefits are cut off. You've reached your max. So you're on your own. So we did do a little bit of scholarshiping there to get them through sometimes in some of these transitions here. And the parents have, especially the father, he has become a pillar in our alumni parent group. So he told me that he feels that he honestly believes that he may not be alive today if it weren't for our parent alumni support group. He's been the hero of many of our parents that are going through the process or in the process, but he's now been in our alumni group for a couple of years since his daughter has discharged, and he finds that to be a great support for him. And then our patients are also offered an alumni support based on their age, so they'll have a teen one, a young adult one, and then a parent one. So when we looked at what it costs typically for nights in an ER bed, a hospital bed, a PHP. When we take all of that, we estimated that his cost prior to us was $180,000. And then after us was about $154,000. So, or that was us. So when we look at that, if we could have really removed a lot of this crisis that you see in the first bullets there, if we had just put her in the right level of care to begin with, we may have even gotten a lot more cooperation out of her with the family therapy, but she was so therapied out by the time she got to us. She had been continuously, very few days in that 8.5 months did she actually spend at home before she had another attempt and then was placed in another level of care. So from the first crisis until the patient was authorized was about 8.5 months, and an additional four suicide attempts. So thank God she didn't complete suicide, but it wasn't for lack of trying, and they were not pseudo either. And what that means is that, you know, she was cutting deeply. She attempted to overdose. She was doing things and not self-reporting. She had very nervous, alert parents on guard at all times that were catching her, and just really, it really made their lives kind of a living hell, if you will, because they were just afraid their daughter was going to die, and there was nothing they could do to help her. And Dad even tells the story that he was preparing for that because it just looked like that's what was going to happen. But he fought to the end, and he did very well for his daughter. So next, I want to talk about the levels of care on the next slide. So these are the levels of care within the mental health industry. The bullets on each one are how Newport treats that particular level of care. So this will vary by state and by provider. The titles of them are basically, with the exception of post-discharge, they're billing terms. Okay. But this is what that billing term typically means as far as what happens in this level of care. So inpatient, when somebody says they are in inpatient care in mental health, that's acute psychiatric. So that's a lockdown, meaning you don't leave one room without using some kind of a key or a code to get out of it. So it's a lockdown. Nobody's going to escape. Okay. That's the highest level of care for a person who is a danger to themselves or others. We take step down from this level of care once they're stabilized. So stabilization in this level of care is typically done with medication. Our goal is typically to adjust medications by giving the appropriate trauma treatment and hopefully adjusting the medications in a way that we're not just dulling the brain receptors out of their feelings, but actually teaching them how to process feelings in an appropriate way that isn't dangerous to their life. So inpatient is typically they will step down once they're mentally stabilized. They will step down to either outpatient or residential. So these are in order of critical. If a person is still in a high acuity situation, you would want to step them down to residential. In the father's story that I just shared with you, she stepped down to a free residential runaway program. So that while it was the right level of care, it wasn't the right program. So you also want to make sure that it's something that the teen or young adult has some buy-in to, that it is scary no matter what they do. They're going to be afraid, and there's going to be some adjustment. It's going to be hard. But the more relevant we can make it to their goals, the more likely that they will relax into the program and surrender to it. When we skip this level of care and just go right to PHP, it would, if that is appropriate, it would be because they're stabilized. Maybe there was just a situation, or there was kind of an epiphany while they were in inpatient to say, oh I didn't mean to do that. It wasn't intentional. And we believe them. Then maybe we step down to either a partial hospitalization or an intensive outpatient. The difference between these two is the number of hours a day that they're in them. Partial hospitalization means they go home every day. So they're doing their schooling, and they're doing any kind of life skills they're doing in this, along with their treatment of group therapies, individual therapies, and in our case, family therapies as well. And that partial hospitalization, it might be 5 days a week for 8 hours a day, or down to 3 days a week for 4 hours a day. It just depends again on how that state regulation is, what the program, how the program is designed. In Michigan, for example, where I am located, a PHP program is a standard program. It's 2 weeks long. That's it. It's like a course. Whereas our partial hospitalization program is very focused on family therapy, skill development, schooling. That's all incorporated into our PHP program. So one does not, lend to the other, as far as they are not all the same. They're billed under the same term, but you want to look at, based on what the individual's needs are, of what the structure of that program is, to determine if it seems appropriate for your individual. Whether this is your kid or your employee, depending on how your wellness programs are designed, we can kind of determine what's going to work best for them. And then the intensive outpatient, again, is a step down from PHP that is typically fewer days a week, and fewer hours a day. And now they're going to engage back into school, into their school program, or into their job if they're a young adult. This again is typically, I know in Michigan, a PHP is 3 nights a week for 3 hours. And with our programs, it could be 5 days a week, or it could be 3 days a week and work their way down to once a week. Just depends again on the intensity and the progress of that person's mental health stability as they are stabilizing. And then we drop down
Hey,
to
Shannon, for finding those therapists on the outpatient services, is that something you guys help with, or how is
yes.
that organized?
Yes, so there are a number of approaches that we go for outpatient services. So when they're ready to step down, almost immediately when they're in the programming, we're looking at what's the end game. What are the resources where they live? And we're going to look at also like what is their plan. So for example, if the employer has an EAP plan that has like one of the virtuals, we're going to look at that as an option. If virtual looks like it would be effective for this, the support for this individual. So there are virtuals, like if the person has OCD, there's No CD is a great virtual program that we could put on their continuing care plan. We can also refer them, we'll tap into our clinical outreach specialist to say, what's in their area, who are the people that you have vetted that, like, where would you send your kid, kind of a thing, and that specializes in this kind of trauma that this person has experienced. I also like to pick places that maybe they have multiple therapists, and they have one that does family therapy and another one that can work with the individual, maybe the teen, and another one that can work with mom on her EMDR for trauma. It'd be great if we can find practices, when we find practices that kind of the family can schedule their appointments like all at the same time, and get their treatment in and go. So there are a lot of virtual resources like that EAP services will do, like Lyra, Rula, Talkspace, Charlie Health. Some of them do only virtual, some of them have bricks and mortar as well as virtual. So we really got to look at what is going to help retain what they gained in the different levels of care that they had prior to outpatient. And that's also something that if we refer more people out than we admit to our program, and that's because they're either overqualifying or they're underqualifying for our level of care. So we will use our clinical outreach specialist to say, admissions got a call from this mom, and this is the scenario, not meeting criteria. They actually put them through quite a rigorous clinical questionnaire. And if they're not quite meeting the criteria, or they need an evaluation in order to substantiate the need, then that clinical outreach specialist can help them identify a therapist that can do an evaluation or provide the service. If we're just like this, the score was low, this can be taken care of on an outpatient basis. If the score is too high, we're going to 911 it, kind of, so to speak. We're gonna escalate it to a higher level of care. So it might not be no, it's just not yet. But in some cases, there might be a rule out in there that would be a no. So if there's a sexual promiscuity, for example, that puts other patients at risk, so we cannot take them, but we can refer them to a place that has that as a specialty in their treatment plan. And that's something that our clinical outreach specialist team would be able to help identify. There's also another resource that I really like to use online, psychologytoday.com. You can actually put in your zip code, your insurance, what type of mental health issues they are dealing with, and it'll keep showing you as you add one more pull down, it'll narrow it down to the therapist in your area that provide that service. And then you can call and talk to them. You can read their profile and say, this sounds like a fit, or, oh, no, I don't think my son's going to like that one. So it's a good tool. So there's a lot of resources. I want to push towards the clinical outreach specialists, not just because they're Newport and I love them, but because while they're vetting for great resources, they're also finding resources they would never refer anybody to. So they're not going to tell you, no, no, don't go there. They're going to say, go here. So there, like in every profession, there are people that do really well and there are people that don't do well at all. The clinical outreach specialists are going to be in touch with that on both ends of that spectrum and help you kind of navigate that. So, finding that partner, if you will, to help identify resources is, the clinical outreach specialist is a really good shortcut for you. And then post-discharge is just maintenance, is maybe every now and then checking in with a virtual therapist, or maybe once a month or once every quarter, depending on how you're doing. If you're doing well, the therapist, any ethical therapist is going to say, you know what, we've got no work to do here. We're done. So, you're doing good. Keep doing that. If you come upon a crisis that you're struggling with, call me and we can talk some more. Okay, next slide. So timing matters. When I shared the story of the father, it had they gone a different route, maybe discharging to Newport to begin with, I think that span of time that she needed to be with us, that 10 weeks would have been much more powerful, because she wouldn't have been so angry and just burnt out. But we got in her brain. Her dad, when I talked to her dad about her engagement, he had said we got our daughter back. She still has times when she starts to fall into some of the old behaviors, but not suicide. She's learned better coping skills. She's learned how to regulate her emotions. And that is what we need to do with those individuals that lack the ability to regulate themselves, and so they feel hopeless to where just dying would be better. That's what we specialize in, is showing them a better way. So the timing of when to send somebody to acute care versus subacute, we are subacute care. So that means they're no longer suicidal or homicidal with a plan. Now, they can be suicidal because they're hopeless and we take them. But if they're like, I got the rope, I got the gun, I've got the, I'm doing this, we want them stabilized first, and we will bump that up accordingly. But then step them down, once they're stabilized. What I see a lot here in Michigan, because of the lack of residential, is a lot of people going to acute psych. We've almost trained the families to present sicker than they are so they can get help, because the outpatient services aren't enough, but then the acute is too much. But some of these kids go into these acute psych places and come out more traumatized than when they went in. So then they're afraid to get help. So just getting the right level of care is really important. And with a good evaluation, we're always going to know whether, we should be considering outpatient or residential. If people just immediately want to know what's your insurance and, we'll fly you here, that would be a really good indication that they're just filling beds. They're not doing an appropriate assessment to determine if their level of care is necessary. And that's what's going to suck the funds out of your benefit pool, because it's not being used in a way that's going to have a lasting outcome for your individual. And as far as family support, it's always good to have family support. If the family support program is a flip chart program, just telling them about addiction and mental health, that's not a family support program. This is therapy, actual therapy for the family. And then support, alumni, people they can talk to and engage with as they're going through the tough spots. Next slide.
Shannon, in regards to the family component of this, are they typically willing to participate, and what happens if they refuse, or how's that play out?
Yeah. For the most part, they're really happy to be asked to engage, because they're, at this point, by the time we've gotten them, they've been kind of pushed to the outside. and the HIPAA has been used on them. You know, we can't share anything with you because of the confidentiality. I remember getting that with my daughter when she was 15. You know, we had a medical issue, but they wouldn't, you know, I had to be there to pay the bill and to get her there and pick her up, but they wouldn't share anything with me because she had rights. So, you know, they're used to that. So when we say it's a required component, they're like, really? Thank you. But now and then, like the family or the father's story, he was one of the individuals that wanted nothing to do with it. He was an Army dad. And things were just gonna go the way he said they went because that's how things are, and I'm the ruler. But he had to surrender because he was gonna lose his daughter, and that kind of, you know, hit him hard to where he's like, okay, my militant way isn't working. Okay, I'll go to that family support group. So mom was going. Dad eventually came, and now he's a pillar of the program. So in cases where there's a divorce, you know, that's often part of the rupture in the relationships in the entire family unit. We can get the one parent, and eventually we can bring the other parent in by just saying that if you truly want to be a part of your child's life, you need to be a part of the solution. And we need to repair some things between the parents because they need to love their child more than they hate each other, which is unfortunate that that does happen, but it does. But they do eventually come around. Now, in there are some rare cases. I have one right now at our Minnesota location with a tribal member whose parents are no longer available to parent. And so the tribe is standing in as her guardian, and they're going to find her a foster. So we'll work with that. We'll work with the tribe. And we will then also offer alumni support to the foster family. Next slide. So this is just kind of a picture of the clinical to client ratio. This is what every client gets as far as their clinical support team behind, you know, the scenes. So they've got a psychiatrist that is doing medication management and looking at, you know, the history, the reactions, all of the notes from all of the different treatments and saying, are we moving forward? Are we, you know, are we not making progress? Do we need to make some adjustments? So that's going to be the psychiatrist. The goal is always to reduce medications because of removal of the trauma. When we process the trauma and we learn emotional regulation, then we can start to reduce the amount of medication a person is on. There's a clinical director that is overseeing the different groups and the different therapists and the programs, and just making sure that kind of all of the cogs in the wheel are doing their part. The individual therapist is a therapist that is going to be working with the patient only, and is working on any of their diagnosis, like their OCD, their trauma, their depression, their anxiety. The counselor is going to work on kind of their behaviors, their maladaptive coping skills, like maybe there's disordered eating, or there's substance use disorder, or maybe there's some aggression or self-harm, cutting. They're going to be working on those maladaptive coping skills. And then the family therapist, of course, is going to work with the parents and with the teen or young adult. He or she works with them individually, and then after they get through certain parts of the attachment-based family therapy, then brings them together in the room, and he or she, the therapist, kind of melts into the wall to see if they're using the skills they've learned, and then reappears if there's a relapse on old behaviors. So the goal there is to help them communicate with each other so that there's a support system in place for the teen or young adult when they discharge, but that also that's a healthy support place for the family. And then they have the teachers and tutors. They're in school. They're using their IEP from their school. So if a person's coming from a different state, they're not unenrolling from their school. unless it's in Minnesota. There's a different law in Minnesota, so they do have to unenroll, but we can get their the credits so that they will transfer back into their school. So for the most part, they're using the exact same school IEP that they'd be using if they were at home. Education is important. It's also often part of the trauma of the child. One of my favorite stories is we had a kid in our Utah location that he was 14, and in his state, you could quit school when you turn 16. So when they, in the original interview with him, his goal was to quit school when he turned 16. And when he discharged, he was with us, I think, 72 days. And when he discharged, he couldn't wait to go back to school to show his teachers how smart he was. So this was an OCD case, and the kid was being traumatized by the way he was being taught in his school. But, you know, put yourself in the place of a teacher with a classroom that's got 30 to 60 kids in it, and you've got an OCD kid that needs special attention, that doesn't know how to study and test as an OCD kid. We were able to teach him those things in our class so that he could then go back and show his teachers how smart he was. So, you know, school sometimes is part of the trauma, and so it's part of the solution. We have the referring providers. So if it was a therapist or a psychiatrist that referred them in, they're going to be a part of that collaborative team and get updates on a regular basis from the team on how they're doing. And then, of course, a medical doctor and a nurse for, you know, medication management, and then registered dietitian. Nutrition is part of our every program. It needs to be, because the function of the body and the brain are dependent on nutrition, sleep, and movement. So we're going to make sure that they're getting good movement and that they're getting good nutrition, and understanding how it affects the depression and anxiety, so that they might be more willing to eat something more than, you know, Cheetos and Slim Jims. Okay, next slide. So we do have outcome studies, and just as far as when you're vetting a partner to have, somebody that will invest the time and effort and money necessary to have an outcome study is what tells you that your money is well spent. So this is actually available on our website at this link if you click it. If you go to newporthealthcare.com, you can work your way to it. We can send that as a follow-up to you. I can send it to you hard copy. It's a pretty in-depth book that, you know, is pretty. Oh, let's do this. It's a pretty in-depth book, but we did have to break it down by age and gender, and then also break out a special section for LGBTQ. Because they all were validating differently. So you'll see the charts slightly different in each demographic because of age, maturity, and then also additional challenges within the certain populations. So if this is something that you would like a copy of, please reach out to me and I will get you a hard copy, an electronic copy, or whatever it is you need. But basically what these outcome studies show is that the way we're doing our treatment is working for the overall improvement of the well-being, a reduction in depression, a reduction in the anxiety, and an increase in the overall wellness and quality of life. And that's the goal. That's the goal. Okay, next slide. Okay, any questions?
So I put that link in the webinar chat. So if everyone on you can pull that up, click on it, and it will get you to the registration page or download page. But you know, a lot of the people on this call would be out of the self-funded side of the industry. I mean, if you had one takeaway for self-funded employers, TPAs, brokers, what would that be?
Identify your partners. And your partners are going to be, if you have signed up with like a virtual EAP, that's a good partner. But even if you have, but they're only virtual, you need a partner for that higher level of care. And I offer you our clinical outreach specialist team. And Heath, I can send you I don't have an electronic link. It's not on our website, but I have a document I can send you that you could share with everyone. Or they can individually contact me. Is there a slide after this one with my contact information? I don't remember. Oh, yes,
I
okay.
think so. There
So
you go.
my email address. And I'll put my phone number in the chat here. Just email, text me, or what have you, and I'll get you that list.
And in terms of, criteria, general guidelines, I mean, I know you had the pillars on the screen in terms of the different areas of care that people might go to, but what would be something to look for your program?
Well, when you have an employee who is really distracted at work, and if you have a wellness plan that they've reported to, or you've identified that this is an individual that might need our help, just have them call that clinical outreach specialist and have a conversation. It's not a commitment, okay? Just ask some questions. They might refer you to somebody local. They might say, we need to bump this up. But regardless, just addressing that issue for that employee is going to give you an employee that is present at work, especially if they're working on a drill press or something, you don't want them distracted. If somebody's got a kid at home that they're struggling, with suicide or self-harm or depression, and they're concerned, you have a distracted employee. You're going to have, look at your employees who have, like, maybe they've got some absenteeisms. Maybe you've seen a change in their behaviors. Ask them, share with them that you're concerned about them because you've seen this change and you want to help them. What can I do for you? And if it's something to do with like what we've talked about today, please reach out to the clinical outreach specialist or me, and let's get them the help they need so that they can prosper in life, that also your business isn't going to take a hit in the productivity and quality because of a distracted employee. And also,
Yeah, oh, go ahead.
when you look at, for self-funded, when you look at your pool of funds and you see a drain happening, and maybe it's it seems like all your funds are going to one or two different families. And unless this is like a cancer situation where, we've got all the tests and chemo and all that's going with that. If this is a mental health issue, that's where we are relevant. This is why insurance companies want to sign us up to be on contract with them. We want to stop that drain on your pool of funds. And the way that we do that is like with the father's story. Let's not spend $250,000 in advance. Let's spend upfront with the right level of care so that we have sustainable recovery that you see in our outcome studies, because that is the least expensive cost of care. The most expensive is going to the cheapest and trying, you saw the cycle. They just kept doing the same thing over and again with that individual, and they were not getting a result. They have a result. They have a daughter that's alive now. And she's not attempting suicide anymore. So now we've got her on a maintenance plan, and that's where you want them. She will make it through puberty. That's the goal.
Yeah. Yeah, I mean, for anybody that's going through this, has got to be a really, really difficult thing. And I'm sure that there's brokers and administrators out there that are running into these claims. If you're working with 6 Degrees, you get access to this through our Pro Plus and contracting program. And if you're not working with us directly, then Shannon's contact information is on the screen. So feel free to reach out. Shannon, thank you so much.
Thank
Really
you.
appreciate your time going through all this. I learned a lot. And let me wrap things up. Lindsay, we got a kickoff for next month. There we go. Dave Chase with Health Rosetta, always an interesting guest, wealth of knowledge and innovator in the space. So join us June 26th at 11 o'clock Pacific. And as always, you can watch all of the recorded Fireside Chats via our website. So go check them out. Thanks, everybody. See you next month.
Thank you. Take care.
Thank you, Shannon. Appreciate it.